Welcome to this short tutorial of a chest X-ray made easy. In this video, I will simplify the approach and interpretation of a chest X-ray so you can feel more comfortable when faced with these studies. Before we look at any chest X-ray, we need to ask ourselves first, is the quality good enough? A simple way to assess the quality is to check for rotation by locating the spinous processes and the medial clavicle bilaterally, then assess if the spinous process is centered between them or not. Next, check for there are sufficient inspiration. We look at and locate the first rib, and from there on we can count the ribs dorsally until you reach the diaphragm. With a good enough inspiration, we want the diaphragm to cross at least at ribs 8 to 10. Next, we need to make up a search pattern to look through the study. This approach will vary between individuals, and of course there's no right or wrong way to do this. Personally, I like to start by looking at the lungs. First at a quick glance at everything, and then we'll split the lungs into smaller areas where we look more carefully. In a normal lung, we should see small white vessels throughout the lung since the alveoli are filled with air. However, note that the vessels should never reach the pleural surface, as this might indicate pathology like pulmonary edema. If the alveoli are filled with pus or fluid, the opposite is true, and now we'll see dark lines representing the bronchiolar tree, also known as air bronchograms. Once we have looked through the lungs, we'll look at the airway. I find this order quite helpful since the position of the airway can help differentiate between different lung pathologies. Either we will look at an airway displaced towards a lobar collapse or pushed away from a large pleural effusion. Now let's work our way down the mediastinal structures. First we want to see a crisp and clear right paratracheal stripe, aortic knuckle, pulmonary arteries, and the aortic pulmonary window. Effacement of any of these structures would indicate pathology, for example tumor. It's important to note additionally that the only way to differentiate between different structures is because they have different densities. So for example the aortic knuckle and the air in the lung. With any dense pathology adjacent to any of these structures, we will lose the ability to mark out these structures. This is also known as the silhouette sign. Now we'll look at the heart borders. They should be easily identified, and the ratio between the heart size and thoracic cage should be within 0.5. The diaphragm should be seen as a clear line with acute angles on both sides. Obtuse angle would indicate pleural effusion. The pleural border should never be seen across the thoracic cage since the heart and diaphragm are of the same density. A lucent line between those two structures is caused by air in the mediastinum. This is also known as the pneumomediastinum. Finally, we should always check for bone lesions and fracture. This is especially true for the clavicle and the spine. And of course, we have to look at the lateral view to look at the same structures, and this is especially useful to spot a minor pleural effusion.